Oh, well, we're going to try part 2 of this video, which I am trying to upload on YouTube. It seems to be taking a long time. I don't have it in the right format or something. If not, I will get a way to get these to you. Anyhow, part 2, chapter 31. We're going on with the gastrointestinal system. I'm going to get these shiny glasses off. Alright, so we're going to talk about pyloric stenosis. Hypertrophic pyloric stenosis. Alright, happens in young infants, it's found. Remember that your stomach has 2 sphincters. It's got one at the top, it's called cardiac sphincter, and there's one at the bottom of the stomach. It's called the pyloric sphincter. The bottom part of the stomach is called the pylorus. Hypertrophic means it's too large, okay? It's overgrown with tissue, and stenosis means it's too tight, so food can't get through. So there's 2 symptoms these babies have. One is projectile vomiting. Every baby spits up. When you feed them, you put them up and burp them. Babies with pyloric stenosis, they spit up, hits the wall. It is very projectile. The other thing is, and the NCLEX always calls it an olive-shaped mass. You can actually feel this overgrown sphincter when you palpate the abdomen. Okay? Every NCLEX will say olive-shaped mass. Okay. The next one is called intrasusception. It's a really long word. Intrasusception. What happens with intrasusception is there's a defect that holds all the intestines together. And a piece of intestine, and usually it's a large intestine that happens with these kids. Actually, it's like a sleeve. It folds back on itself so that you get like a folding up, sort of like this. Can you see what I've done here where you folded it up? What happens when they folds up this way is that they get a blockage. They can't pass stool. It's extremely painful, and they have what's called currant jelly stools. Why they call it, I don't know. I've never seen currant jelly, but I'm assuming it's this red gelatinous kind of jelly looking thing. Interestingly enough, depending on the baby's position, if the child changes position, the piece of intestine can relax a little bit and smooth out and then fold back up again. So it's kind of hard because the pain can be periodic. They can be screaming in terrible abdominal pain, and then all of a sudden they move just right and this thing relaxes some and the pain goes away. Fixed by surgery. Oh, just like pyloric stenosis, he's fixed surgically. Kids can eat again. In this case, they have to remove that loose, bad piece of intestine, and the kids are fine. But it's very bad when it happens. So they get some abdominal bleeding, they get pain, that piece of intestine can die in there. So, surgical fix, take out that little bad part, re-anastomose the 2 ends, baby's okay. That's intrasusception. Hirschsprung's disease. Hirschsprung's disease is something that is also usually a congenital kind of thing. It seems to go along with other anomalies. Down syndrome is the biggest thing it goes along with. And it's also, you'll hear it called megacolon. So what happens is the lower end of the colon just becomes very, very stretched and dilated and doesn't have motility. It loses its muscle motility. So they end up that the stool goes around the intestine and then gets down to that part and just fills that part. They get a blockage. They get like signs of obstruction. They get abdominal pain. They get a very distended abdomen. Again, this piece of bad colon has to be removed. This is not something we can get along with fine. They get constipated, terrible, and just can't even pass any stool. Hernias, you kind of know what a hernia is, okay? Is when a piece of the abdominal wall that covers the abdomen, there's an opening, a loose spot. Babies get hernias around where the umbilicus goes in. Remember, there's a hole there, so all those 3 vessels from the umbilical cord can go in. It creates a weak spot in their abdomen. A number of babies get umbilical hernias. As long as you can push them in, they're fine. Many times they will actually build abdominal strength and wall and that place will seal up and they'll stop getting the hernia. Once in a while, they have to repair it by sewing that little spot together. Remember with hernias, if the piece of intestine gets stuck out, that's incarcerated. If it gets the blood supply cut off, it's strangulated. Doesn't happen often with umbilical hernias, but there's something you want to keep an eye on with a kid. I'm not going to go through urinary tract infection. We just know little girls are way more susceptible because little girls have a very short, tiny urethra, and they don't sometimes want to play and not take baths the way they're supposed to. Get over that. We're going to talk about nephrosis and glomerular nephritis together. Okay, these are two things that are inflammations of the kidney. So it's kidney disease in kids, all right? With nephrosis and acute glomerular nephritis, the whole difference is where the inflammation begins. Symptoms are the same. These kids get very, very sick. Think of, how sick people are when they have kidney disease. They end up on have dialysis. Usually you don't need to do that with kids, but they are very limited. They become very, very edematous. That soft little child baby skin gets very edematous, and it's very easy to break down. So there's two things we have to watch for with these kids. One of them is that they have to their skin has to be monitored extremely carefully for skin breakdown. The skin is just soft and squishy and full of fluid and breaks down instantly. The other thing is these kids need to be rest. How many kids like to rest? Bed rest for a kid? That's tough. That's what these kids need. So they're really pretty sick, even though when kids are pretty sick, they still want to get out and play. They do a lot of diuretics for these kids. They watch them very, very carefully. They give them a lot of anti-inflammatories. Now, if it's a little one, it's a baby, and here's a question that always comes up on NCLEXs and things. Pay attention. If it's a baby, how do you measure accurate intake and output? Because they're peeing into a diaper. Well, you weigh the diapers. You know what the diaper weighs ahead of time, and after it's full of urine, you weigh it again. Because urine weighs about 1 pound per... Let's see. I think I'm trying to remember the conversion. Maybe you should look it up. But anyhow, for every ml, 100 mLs, I think, of fluid, it's like 1 ounce of weight. So you weigh the diapers, and then you use your little formula, and you can see actually how much they put out. All right. Wilms tumor. Wilms tumor is a tumor that happens in the kidney. Nephroblastoma. Wilms tumor has a congenital component that adults who've had Wilms tumor can sometimes have kids who have Wilms tumor. You can actually feel these tumors through the abdominal wall. A lot of times this necessitates having one of the kidneys removed where this tumor is. It's not something that you need to go through a lot of chemo or radiation for. It's just removal of the tumor. But then these kids have one kidney the rest of their life, which means they have to be very careful with that one kidney the rest of their life. You can live with one kidney, but if something happens to that one, you're in big trouble. So that is the GI tract. We're going on to, oh no, wait a minute, we still have structural defects. Yeah, we got it. All right. Structural defects of the genital urinary tract. And the one we're really just going to talk about, there's a defect that happens with boys. It's called hypospadias. And this is where the opening of the urethra is not at the tip of the penis where it's supposed to be, but maybe anywhere down lower on the underside of the penis. Everything functions normally. You have your bladder and everything is fine. It's just the opening of the urethra, the meatus. What this causes is some real bad psychological issues. They do try and do things to repair this. I mean, who wants to be in school into a locker room and have other little boys notice that your penis doesn't look like everybody else's? So they can correct these, and they usually correct them when they're young before these kinds of things happen. Okay. Oh, now we have endocrine function. Hypo and hyperthyroidism. Just as in adults, the same thing. Either the thyroid gland underfunctions or overfunctions. But here's the difference. Hypothyroidism, very closely associated with Down syndrome. A lot of Down's kids have hypothyroidism. If you do not correct this, it causes mental and cognition difficulties later in life. You want to test for hypothyroidism on kids who are not acting have symptoms of hypothyroidism. That's usually they're very, very tired, they're very, very cold, they don't have energy, etc. But especially with Down's kids, because this hypothyroidism along the line will cause mental slowness, cognitive difficulties. So we correct hypothyroidism as well as we can. The other term that continues to show up in your books, and this is kids who are born who have a non-functioning thyroid, is called cretinism. You don't see cretinism anymore now that they've figured out how to make synthetic thyroid hormones. It used to be a problem back in the old days. Doesn't happen anymore. Anyhow, but you'll still see this word cretinism sometimes in the NCLEX. Excuse me, coffee. Diabetes. We're not going to go too depth into that because we've done diabetes up and down. But you have to know that when kids develop diabetes, when it develops in kids, it's always type 1 usually. And can start at a very young age, can start when they're toddlers, can start when they're 5, 6 something years old, can start as high as 8 years old. Very difficult to control for various reasons. One, you've got kids who want to eat like every other kid and have to shoot themselves with needles and do their blood testing, etc. Two is because they're kids and because their bodies fluctuate so much and they go through growth spurts and they go through hormonal changes. It's really difficult to get a good tight control on the blood sugar of a kid. Very difficult. Leads to a lot of problems. A lot of times leads to episodes of DKA, that diabetic ketoacidosis. And when it starts with young kids, this is when the lifelong damage is caused, and it can damage the kidneys and damage the eyes. I know one young boy's from Dansville. If you look up, oh my goodness, I lost it right away. He's developed diabetes when he was 8 years old. His mother works with me in the radiology department in Noise. I think I've talked about this young guy before. Carter, his name is. If you look up Carter's Crew on YouTube, you'll see a lot of stuff. He's done interviews and things. And these are very aware people. Very aware people. And they try and tightly control him. And they actually have gotten the system now. They went through a huge process to get this system where he has not just an insulin pump, but he's got a little gadget that goes alongside it that continually monitors his blood sugar and alters the dosage of his insulin pump. And you will see episodes again and again, and these people who are so concerned and so aware of where he goes low blood sugar. If he's doing sports or something, even though he's eaten something. Or whether he goes high blood sugar and they don't, there's no reason for it. All of a sudden the kid's blood sugar just jacks right up and he's not getting enough insulin. So it's terrible to control in kids. Leads to lifelong damage. Okay, so that's all we're going to say about diabetes. Musculoskeletal disease. Alright, we're going to talk about this one. It's called dysplasia of the hip. Alright. Developmental dysplasia or congenital dysplasia of the hip. This is when babies, for whatever reason, when they're born, their hip joints, their hip sockets are not tight and intact the way it's supposed to be. Their ligaments and everything are loose. So they actually have the hip bone, the top of the femur here, is not actually in the socket or the way it's supposed to. How you treat this actually is very simple. You don't need surgery for these kids. They have this little thing, it's called a Pavlik harness. And what it does is a little strap that wraps around their abdomen, and it holds their little legs out in abduction, just like we abduct someone after hip surgery. It just holds those hips out into place that way and gives the child time to develop the muscle and the structure that they need so that they have normal hips. So you just keep this little harness thing on the baby that holds their hips out like this, and after a while, when it's strong enough, they're out of it. So if you ever look up, you can look up pictures on YouTube or Google of this Pavlik harness. You treat it the same, abduction, like you do a post-hip repair. Leg calf Perth's disease is a problem that happens a lot in especially girls, teenage girls, whereas they get a growth spurt, they get joints that do not grow quite as well. They can get some necrosis areas. It happens in the knees. It causes a lot of pain. What you do for that, it's this unexplained pain. My knee hurts, my knee hurts, my knee hurts. Okay. What you do with that is a lot of times, unfortunately, these girls cannot do sports. If this happens to them, they get taken out of their sport because it's the constant wearing on this knee joint that hasn't developed as fast and work as well as the others. And time and exercises to help build the joint. And really, sometimes that's all you can do. It's usually self-limiting, but it's a problem with a teenager who cannot do the things that they want to do. Scoliosis. All right. If you remember, you have two curves you're supposed to have in your spine. You have lordosis on the bottom. You have a little kyphosis on the top. Scoliosis is when the spine bends sideways. It is not supposed to do that. It causes multiple problems if it's untreated. Because when the spine bends sideways, it will actually compress parts of these rib cage so that they can't breathe on that side. It can cause problems with compression of the heart, causes pneumonia, all sorts of difficulties. Scoliosis tends to manifest or show itself as kids go through growth spurts. And when they start getting tall, and we're talking early preschool years, or not preschool, I mean early middle school years. That's when girls go through their growth spurts. All of a sudden, they start to notice this curvature in the spine. That's why they do this test. How do you test for scoliosis? You have a girl stand up with her feet together, and you have her bend over and touch her toes. You should see a very straight spine. If you see a curve at all in the spine, you're beginning scoliosis. It can be treated with bracing. It's very uncomfortable for girls, and it's something that they, you can get picked on. Here you're going around with this back brace all through high school. You can't do sports. You can't do all sorts of things. However, bracing is an invasive way for this to work and to fix the spine. If not, it needs to be a surgical fix. And now you've got someone who's got a very fixated, stiff spine from the time they're a teenager onward. So you really try to avoid surgery. So they get into a full, body, spinal brace that keeps them in line and usually will correct the problem. And hopefully we don't have to go through surgery. All right. Osteomyelitis is next. It's a bone infection. A bone infection is a bone infection is a bone infection. Even with kids, very hard to treat. Not going to do that. Talipes, clubfoot. Can happen for a number of reasons. Can happen for just from positioning in the uterus when the feet get turned in because they're squishing in the uterus. Can be a congenital thing. Sometimes they are runs in the family. Clubfoot needs to be fixed. You can't walk like this on the side of your foot. You end up with a big deformed foot and humongous problems and skin problems on the bottom. They try bracing first. There are braces they can do with kids that actually work like little casts that they can put their feet in position It's real uncomfortable. If you're a baby and you've got your feet in these braces, and what they do is they got like baby shoes with a bar between them, and you put their feet in the baby shoes and it's held like this. And if you think about how little babies like to wiggle and move around, and now their feet are stuck in this position, really not great. If it's severe enough, they do surgery very young. They do surgery before they start to walk. They do things to correct this foot and get it in the proper position. So now you got a little baby in a cast. You got to be really careful about skin care and stuff like that. But it needs to be corrected before they're up and walking. So before the age of 1. So these poor little kids undergo surgery when they're very young. Okay. Duchenne's muscular dystrophy. Muscular dystrophy comes in many forms. Muscular dystrophy is a degenerative nerve disease. With Duchenne's, is a particular kind. It happens in kids. They get destruction of the, it's not the myelin with Duchenne's, but they get destruction of their nervous system, where they very slowly go through a process where they weaken. It starts usually in the lower extremities or out in the hands and progresses up until the kids become paralyzed or unable to move all the way up. Lifespan with kids with muscular dystrophy is generally teens and 20s. They will usually, what they die from is from respiratory failure, because as their muscles progressively weaken, so don't the muscles in the chest and the diaphragm, and they end up with lots of pneumonia and they weaken. There is no treatment yet. They're looking at stem cell therapy, which would be great. You're always going to see on your NCLEX things, you're going to see this called Gower sign. And that's as kids weaken and they can't stand up straight on their own, and they actually walk themselves up their legs with their hands. That's called Gower sign. How this you usually notice with these kids is kids who are active and playing, etc. All of a sudden you notice they're falling, they're stumbling, they're weak. They can't seem to do what they used to do. And they do testing for muscular dystrophy. It is difficult because it is a death sentence for these kids, and they know it, but you treat these kids like you treat kids. You treat them like you treat them. But you do know that most times by a very young age they're in a wheelchair, and then you have all the things that are associated. You have to watch their skin, you have to watch for pressure sores, you have to watch them with eating, because as things weaken and they lose muscle control, they have difficulty swallowing. So it's progressive neurological disease. It's horrible. Research continues. What? Septic arthritis? No. Okay. Fractures. Fractures happen with kids all the time. Right? Just know that we will talk about in a little bit. Oh, I'm going to sneeze in a second. I don't want to do that, because if I stop this, I have to restart the whole thing. With fractures with kids, there are common places where they fracture. Usually, like I said, it's long bones, wrists, fingers, the skull sometimes, depending on their activity. What you need to know with fractures, if you have a kid with a fracture, is that the fracture should be reasonably explained. All right? Babies have very, very soft bones. Babies don't get fractures as much. If you get a baby with a fracture of a long bone, that takes a lot of pressure. And if there's not a great explanation, first thing you suspect is abuse. Right? Kids break their wrists all the time. That happens. They fall off of things. They break their wrists. Kids don't break their humerus as well. And is this wrist fracture? Is this spiral fracture explained? Would they have a hold of a pole or something and they were swinging around and then it broke? Because there needs to be an explanation for this spiral fracture that makes sense. One of the biggest signs of abuse is that the child's injuries don't match the parent's explanation. You should trigger right in your head. Abuse, abuse, abuse. As nurses, if we even suspect abuse, we report it. We don't say, oh, I bet it's only a suspicion. Because if a child's been injured like that and you have any suspicion, a reasonable suspicion, you really need to act on it. It's for the safety of the child. You are protected by law that says you had a suspicion. It's, you know, you're not going to be able to be sued or anything for that. Anyhow, with fractures, all right, casting, immobilizing, rest, ice, elevate, compress, which is the fracture. Hey, there was 5 things. Rest, ice, elevate, compress. All right. Watch the skin around the cast site. What do we use for kids who fracture or any kid with a serious disease from that pain medication? And this question's come up on there. We use opiates. We use morphine. It works. These kids are in pain just like adults. Opiates are safe for children as long as you do weight-based dosing. It's the same, no different risk than an adult. Okay, you still keep an eye on them. We know kids process drugs differently, so you watch their respirations, etc. But opiates in general are very safe for children and is what we use for pain. Morphine is a very safe drug. So if it's used properly and it's used by the right dosage or the right weight. So questions always come up. Put it in your head. Yeah, we use opiates for kids for severe pain. Okay. Meningitis. Meningitis is a inflammation and infection in the wrappings of the spinal cord. That's in the spinal cord. If it gets around to the wrappings of the head, that's called encephalitis, which is even worse. Meningitis is a fatal, life-threatening condition. There's 2 kinds of meningitis. There's a viral meningitis, and there's a bacterial meningitis. Okay? Bacterial meningitis can become fatal very quickly. Kids can go from acting like they have a fluish kind of thing one day to dead the next. Bacterial meningitis is extremely, it just happens so fast. Viral meningitis can also be spread easily. It happens in places where kids come from different areas of the country where things are. College dorms, and all of a sudden congregate in a crowded area. Now they vaccinate for meningitis, and now it's become mandatory. It wasn't until just recently this mandatory vaccination at age 16 of meningitis, and all these freshman kids would go to college in their dorms, and bang, a whole dorm floor is on quarantine because there's meningitis on there, and that ruins your experience of college when you just go to start in college. Anyhow, so meningitis. Symptoms of meningitis: neck pain and stiffening, severe headache. Signs that you're sick: you have a fever, all right? There's 2 different signs. One's Kernig's and one's Brudzinski, and both of them show these irritation of the spinal cord. What's the difference between them? Just remember Kernig's and Brudzinski, because you do one, then you do the other. One of them is you take a kid and you kind of fold them up a little bit, their head and their knees together, and it causes pain because it stretches those wrappings of the spinal cord. The other one is you have a kid laying there and you put their leg up and then you bend their knee down, and it causes pain because it stretches the spinal cord. Which is which? Who knows? It's Kernig's and Brudzinski. They do them together, and it shows pain and irritation of the meninges. Okay? Kids with meningitis, suspected meningitis, go into airborne isolation. Those are the isolation rooms with a negative pressure flow. Airborne. They need to go into it because it's very contagious. The viral one is very contagious. Airborne isolation, they stay in there until they're on antibiotics for 24 hours. Once they're on antibiotics for 24 hours, they can come out of that isolation. They never take them out. They'll be in it for their whole hospital stay because they don't want to take any risks. But 24 hours of antibiotics and these kids can come out. However, it has to be recognized quickly and treated very quickly. Remember, bacterial, these kids go from acting like they might be coming down with the flu to dead within 24 hours. So it needs to be acted on very quickly. As I said, encephalitis is the next slide. Encephalitis is when it goes to the brain. Then you have a brain infection, and then you can have long-term cognitive defects. Don't want that. I'm bypassing hydrocephalus because we're not going to talk about that till we talk about spina bifida. Okay. Which is it in here? Ah, yes it is. There it is down there. Okay. Cerebral palsy. Cerebral palsy. Should get my buddy and Brady to talk to you guys. Cerebral palsy is what happens when there is deoxygenation of the brain in utero or during birth. Or actually, in my pal's case, he was a normal baby. He had a very, very severe reaction to his first shots. He had a bad reaction to the diphtheria component and went into cardiac arrest, and this is what caused his his cerebral palsy. So, symptoms of cerebral palsy vary from mild to where it's like down one side of the body where you may have one hand that doesn't work as well and leg, to severe where it affects every part of your body. Sometimes there is cognitive dysfunction along with it. Sometimes they're not. Sometimes you may have a kid who cannot move parts of their body and is completely intact mentally. It's kind of difficult for them. And what happens when these parts of the brain get damaged? It damages their motor centers, and they actually get spasms. It's just constant. Their muscles, instead of being able to relax, are constantly tight, and there's constant spasming. They have a very particular walk. It's a toe walk that they do because the backs of their legs spasm up. So they walk on their toes, kind of, in a odd way. They have difficulty controlling, if they want to eat any small motor thing, because as they're trying to do something small motor, these muscles up here spasm and take their arms and, their limbs places where they shouldn't be. They can have difficulty speaking. Because they have to be able to control the muscles of their face, and the muscles of their face are spasming weird ways while they're having difficulty speaking. They can have difficulty swallowing because there is, a component of that where you have to consciously do the swallow motion, so they can have difficulty swallowing. Treatment for cerebral palsy is all based on keeping them mobile and as much self-care as possible. Mobility is the key to everything. Getting these kids the ability to walk is so important. And I've seen it with my kids at camp. I've got one girl, she was brilliant. She went to college. She was great, but her mobility was never there. So now she's in a wheelchair for the rest of her life. All she can do is stand and pivot. Very, very, very limited in what she can do because of that. And then we have Brady, who, even though he has a lot of difficulty walking, can walk. They worked really hard getting him able to walk. He has a job. He's able to do stuff, So mobility is really key with these kids. And going through keeping as much self-care as they can. It's all about being able to take care of yourself and living on your own as you get older. There's no age limit where you die from cerebral palsy. You have this all your life. All you can do is try and maintain function and keep your function level up. It takes a lot of training. Can you imagine needing to train yourself to be able to talk? Something that kids do from 2 years on. So this is how it is for them. Okay. Seizure disorders. There's all sorts of seizure disorders. They don't usually just classify as epilepsy, although epilepsy is still a diagnosis. They know now there's multitudes of kind of seizure disorders. Sometimes it is from damage during birth in utero. Sometimes it is a congenital thing. Kids are born with it. Most of the time, seizures can be very well controlled. Most of the time. However, these seizure medicines are really harsh on kids. Seizure medicines are really tough on kids. One of the best ones that work so well is Dilantin. Dilantin causes all sorts of awful side effects. They're always developing new seizure medicines that work pretty good. You will notice, though, that kids with severe seizure disorders are normally on a different multitude combination of medications. They have to tinker their whole lives to try and get this combination right so these kids stop seizing. And like other things like diabetes, as kids go through growth spurts and hormonal changes, all of a sudden seizures that were controlled reemerge. There can be a cognitive developmental delay component that goes along with seizure disorder also. So, but it's something that, if you're a kid and you want to be like every other kid, you don't want to drop and start thrashing and drooling and making noises in front of other kids. So, it's something we try and really keep good control of, good medical control. You know that there are ones, they used to call them grand mal, now they call them tonic-clonic seizures. They're whole body seizures where you get a stiffening and a relaxing and a stiffening and relaxing. If you have someone with a whole body or tonic-clonic or grand mal seizure, all you can do is protect them. They will fall, obviously. They're unable to stand. Roll them on their left side. You need to keep them on their side, so if they drool a lot with the seizure, there's a lot of excess drool, and you need to keep them on their side so that drains out and keeps their airway open, and you wait for the seizure to stop. It seems to take forever. Some kids have Valium that is a rectal injection, it's Valium, it's a gel kind of thing that they inject into the rectum if the seizure lasts over 1 or 2 minutes. There's something as a teenager you don't want anyone to see also, okay? Keep that in mind. Some of them, they call them partial complex. They used to be called petit mal. Now they're called partial complex, where it can be just one small part of the body having a seizure. You'll notice them doing eye-jerking movements or smacking or lip-smacking kind of movements or something. The thing that's with partial complex, or what is called petit mal seizures, is when that happens, the brain is firing neurons like crazy. The brain just all of a sudden goes crazy and fires. They are not aware of their surroundings during this thing. They may be sitting there and just sort of making some smacking movements. They are not aware of what's going on around them. They don't know what you're telling them. They don't get the instructions. They don't hear things. So we want to keep those under control also. Okay? That's seizure disorder. That's pretty much the nutshell what you need to know. Okay. We are going to talk spina bifida. All right? Spina bifida. Myelomeningeal seal. And we'll talk hydrocephalus with it because the two of them tend to go together. Okay. Sometime in the early development of the fetus, part of the wrapping of the spinal cord, those meninges, and the bones of the spine don't form right. And if the bones of the spine don't form right, it leaves a space for those meninges to just go right out of the spine. I don't think I can get a good drawing of it, but anyhow, there's a hole in the spine. The meninges come out. If the nerve comes out, it causes paralysis from that part of the spine down. Where's my thing? There we go. All right, yeah. Ooh. Still got old stuff on here. So, what happens to the kids depends on the level of the spine. Remember, long ago we did this dermatome thing that showed which parts of the spine controlled which parts of the body. So, if you got a kid and this is their spine, there's their legs and arms. Yeah, that's a kid. Okay, and right here, you have a defect in the bone that allows the spinal cord to bulge out. From that level down, you can have paralysis. You can have loss of sensation, right? This is spina bifida. As I said, it depends on where the lesion is. If the lesion is up high, they can be paralyzed their entire lower body. If it's even up higher, they can have some arm component. If it is down low, like down here, down low, they may be able to walk. They may have control of part of their arms and legs. But no matter where it is, the very bottom of the spinal cord controls the perineal area. no matter where this defect is. These kids will need to be taught, be catheterized for the rest of their life. Be taught self-cathing, and then they will have to go through regimens so they can control their bowel movements, or they wear a diaper for the rest of their lives. No matter what, kids with spina bifida have elimination problems. Okay? So, whether they can walk or not, it all depends. Because there's a defect here. Now remember, this is where we're going to get hydrocephalus. Right? Way up here in the brain, inside this area called the ventricles, is where you make your fluid that surrounds the brain and ends up running down the spinal cord. This is the fluid that is in the spinal cord, and is supposed to drain out down here into the abdomen. If you have a defect, your drainage system is blocked. So the pressure builds back up and up here. And you get this buildup of cerebral spinal fluid around the brain. Hydrocephalus, water on the brain, is where that comes from. Kids with spina bifida almost always have a component of hydrocephalus. Obviously, if you fill your brain with water, the brain tissue shrinks and causes some severe cognitive problems and enlarging of the skull and all sorts of things. So there's a way to fix this. They give these kids what's called a shunt. Okay? So what they do is they take this little tiny, well, it's long, but it's very, very small, like a catheter tube. And they go in with the surgery and they put the catheter in right here, and they run it down their body, and it empties out into their stomach. There's their shunt. Drains the brain, goes down into the stomach. These things need to be tested or checked often to make sure they're functioning, right? If they stop functioning, then we get water buildup again, which is a problem. So, what's the first sign of a non-functioning shunt? Something's gone wrong. This kid grew up too tall. There's a kink. Something's happened in the shunt. It's the same signs as a really bad migraine. If a child who you know has a shunt complains of headache that goes along with nausea and vomiting, just like a migraine, because it's affecting their brain, they may have a shunt malfunction. We get on that quick and we treat it quick. Okay? So, signs of any brain irritation, any problem. Headache, nausea, and vomiting. Think migraine. Okay, spina bifida kids, it is a lifelong process because if they have paralysis from anywhere from the chest, waist down. They may be in wheelchairs. Some of them can walk, but there's always a paralysis of some part of the legs. They will need bracing the rest of their lives. But they can do pretty well, some of them who are able to ambulate, but they always need to self-cath. They need to be taught self-cathing. They need to be on antibiotics all their life to prevent UTI. They need to undergo a bowel regimen because their bowels won't evacuate, voluntarily, and we don't want it to do it involuntarily. With girls, because it's hard to self-cath, they have started taking a piece of the intestine and creating a little pocket inside. There's a stoma right by their belly button that they put the catheter in. They will do things too to help them evacuate the bowels. They can do various surgical procedures. So that's spina bifida. Myelo, which means the wrappings of the spine. Meningeo or meninges. Myelomeningocele is the other one. Okay. Skin contact dermatitis. Contact dermatitis. Like what? Poison ivy. Alright. Wool. Itching. You get redness. You get rash. It's not infectious. You put on stuff to stop the itching, redness, and rash. Difficult with kids. Don't let them itch that and pick. Yeah, they get picked. They get scars. Diaper dermatitis. Alright, we just need to know the difference between plain old diaper rash and a yeast rash. Remember, yeast is very small, tiny red spots that grow together into a big reddened area. With diaper rash, we teach parents to try and keep everything as dry and clean as possible. We can use, barrier creams, diaper ointment, diaper rash ointment to protect the skin. If the child's got diarrhea, oh my goodness, all of this that burns their skin instantly, So you really need the diaper cream. However, that will not work for yeast. You have to see a doctor. You have to get nystatin cream for yeast. If they get yeast anywhere, thrush, you have to get the nystatin swish for the thrush. So there's nystatin swish for thrush here. There's nystatin cream. There's nystatin powder. Somehow questions always come up because the yeast starts to go away and it feels good after 2 or 3 days and kids want to stop taking their medicine. Same as antibiotics. Take the whole thing. Okay? Always take the whole thing. Atopic dermatitis or eczema. Some kids are really prone to this. Remember when we talk skin eczema, what do? We try and keep it as moist as possible. Moisturize, moisturize, moisturize. Alright? All of these things. Acne vulgaris. Alright? Acne vulgaris is when you have kids whose sweat glands go out of control. One of the big things that's always gone on, well, acne vulgaris, well, they don't wash their face. Why don't they just wash their face? Doesn't work if they have this disease, all right? They can wash their face, and within an hour, they will be oily and greasy again, right? It's out of control sweat glands. This is not a matter of cleanliness. However, we've all known kids growing up who've had this in high school. And what were they told? Oh, they're greasy, they're dirty, blah, blah, blah. No, it's not a matter of cleanliness, okay? There are ways that you can treat this. There are medications that can treat this. However, the biggest one is called Accutane. It works great. It takes care of acne vulgaris. It is also very teratogenic. And we're talking teenagers who could be sexually active. All right? So, Accutane for acne vulgaris. These girls have to be taught very implicitly, they cannot get pregnant. They are put on birth control whether they are sexually active or not. They're monitored because the birth defects with Accutane are horrible. Right? You don't want that. Okay? Psoriasis happens with kids too. Psoriasis is when there's an overgrowth of the skin and they get actually plaquing fish scale. Yeah, kids are going to get picked on if they get scaly stuff. There are treatments for psoriasis also. They're very kind of nasty, mostly creams, or they can do injections. It's tough with kids with psoriasis because they're going to get picked on. Anything that alters your appearance at all, a kid's going to get tormented for. They do have these new ones that stop this overgrowth of tissue. It's almost like an autoimmune thing, psoriasis. It's related to arthritis and autoimmune diseases. So they can use autoimmune medicines for it. However, that puts kids at big risk for infection. Right? Herpes simplex virus type 1. Herpes zoster. Right? Herpes zoster. Chickenpox. Chickenpox. We're going to talk chickenpox a little bit. Remember, it's zoster. Alright? First of all, the symptoms of chickenpox start like almost impossible to detect symptoms of early cold. Oh, a low-grade fever. Oh, a runny nose. Oh, I just kind of don't feel good, Mom. I'm a little headachy. You gonna keep your kid home from school? No. Unfortunately, the 7 to 10 days of prodromal syndrome, guess what? They're infectious. This is why chickenpox spreads so much, and this is why we do a chickenpox virus now. Because your kids with a little bitty maybe cold symptom, not too much, don't feel so good, got a low-grade fever, is going to school and infecting every other kid there. So, this is why we vaccinate, right? When the lesions appear, they are blistery, watery, awful looking things. They crust over. The kids are infectious until the scabs, the lesions are all crusted over. Right? Usually it starts in the trunk, the face, the body, and then it spreads out to the arms and legs. So as long as there's new lesions forming, new blisters forming, they're infectious. And it's not until the whole crusting over, and this can take 10 to 14 days that this kid can be infectious, beyond the prodromal stage. Okay? So, vaccinate your kids. Don't get chicken pox. We adults who didn't have vaccines for chicken pox, who all got chicken pox, now get shingles. What was the latest stat? 1 in 3 adults who have had chicken pox are going to get shingles. You don't want shingles. It's really bad. Okay. Tinea capitis corpus pedis fungus. A fungus among us. When we say tinea, I don't know why that swiped over that way. When we say tinea, right? Remember, there's difference between pediculosis, which is lice, and tinea, which is fungus. This is the fungus among us. All right? When we say pedis, it is athlete's foot. When we say pubis, this is what kids get, jock itch, etc. Fungus among us spreads pretty rapidly in gym areas, in showers, etc., etc. You need antifungals to take care of it. There's over-the-counter antifungals that you can use to take care of your tinea corpus penis or pubis. So it's painful. You get cracking, crusty, scaly skin, and it's painful, and it's red, and it's hot. So treat it, all right? Try and give your kids shower shoes or something so that they're not walking on other floors where some kid with athlete's foot may be walking. You usually don't need to have prescription medications unless it's really out of control. We talked about thrush. We're going away from that. We're going to, there's our pediculosis, lice, and scabies. So now we got to remember these 3 things, because in the last, when we did skin, we had trouble differentiating between pediculosis, which is lice, losis is lice, pediculosis is lice, scabies are the little mites that burrow under the skin, scabies skin, and tinea, I don't know how you're going to remember that tinea is jock itch, but there you go, tinea is a fungus, okay? All of these can be very contagious and spreadable through schools. So we try and treat them thoroughly when we get pediculosis and scabies, right? We have to do the lice treatments and the scabies treatment. We have to wash everything in your house, including your couch cushions and your rugs. You got to shampoo your rugs because kids roll around on the floor. They used to do lice checks at school. They've given up because they would send a kid home for lice treatment. The parents wouldn't treat the rest of the house. The kid would come back with lice 2 days later, and now we'll go through the whole thing again. So they don't do lice checks anymore, but realize that if you have a classroom and you have a kid with lice, you're going to have a couple other kids. It is close contact that spreads these things. Everything needs to be treated. Okay. Let's see. I think I am going to stop right here on this second one because it's been almost an hour again, because the next thing are our cognitive impairments, which is a whole different kettle of fish, and they're a whole nother thing. So, I'm having a little difficulty uploading, but I am getting them on a flash drive, and I may have to pass them along somehow. I'm not sure. I'm trying to upload these to YouTube. So this is the end of part 2 of chapter 31. There will be a 3rd video, obviously, and that should be it. Part 3 of chapter 31, because I'm getting tired of talking. Alright. Oh, it's still going. Stop. Stop. Hey.